Good evening, ladies and gentlemen. My name is Charmaine. I head up Thoroughbred Breeders Victoria, for those of you who don't know me. Tonight, I'm joined by our good partners and friends at Avenel Equine Hospital. We have Alex and Liz joining us, and they're going to take us through a few topics tonight to wrap up our series of webinars that we've been doing now for the past 2 weeks. Which have been fantastic, and we've had a whole lot of different topics. Webinars will be available post next week when we record them. So they're being recorded. We're just working on a few bits and pieces. How are you going, Alex?
Yeah, good. How are you?
We've had an event tonight, but we'll get there. So Alex is going to present conditions of newborn foal to us. And before I let Alex take the stage, I'm going to give a bit of a background about her. So Alex graduated from the University of Melbourne in 2013, following which she volunteered in Morocco, assisting local veterinarians to treat all types of horses, donkeys and mules. That would have been quite an interesting time, Alex. On return to Australia, Alex took up a position in Ballarat, where she worked in a mixed practice that had special interests in equine stud medicine, neonatal foal medicine, and racetrack practice. Wanting to develop her skills as an equine clinician further, she accepted a position at UVet Equine Hospital in Werribee, where she was involved in a large number of surgical and intensive medical cases, as well as advanced diagnostic imaging and lameness workups. During her time at UVet, she had the opportunity to complete specialty rotations in diagnostic ultrasound and sports medicine at the New Bolton Centre, Philadelphia, as well as training in anaesthesia and clinical pathology. Since beginning at Avenel Equine Hospital in 2018, Alex's role has encompassed looking after hospital and surgical patients, as well as sales work, export work, and reproduction. Alongside neonatal medicine and critical care, Alex's particular interests extend to diagnostic imaging, ophthalmology, and sports medicine. Alex is currently working towards a dual advanced practitioner status in the fields of equine internal medicine and equine diagnostic imaging through the University of Liverpool. Alex, I'll let you take the stage.
Thank you. Hi, I'm Alex. As Charmaine said, I'm now coming up to my 4th season at Avenel Equine Hospital, where I've predominantly worked in the hospital looking after our neonatal foals, as well as some of the other things that Charmaine mentioned before. So this talk is largely going to be focused on the neonatal conditions in the foal. It's obviously a very broad topic. So I'm just going to be focusing on a snapshot of these conditions that you might be exposed to in a farm setting, although given there is a lot of sort of overlap and rapid progression of some of these conditions, quite a lot of these conditions can progress and become hospital cases as well. So we'll sort of touch briefly on everything. Some of this might be stuff that you're already well aware of, but it is just a very brief sort of overview of a lot of cases. So just, I guess, before we start, it's worth mentioning that many foal illnesses are on a spectrum. There are some foals that show very subtle signs of not being quite right, to very severe, obvious signs that something is going wrong. To make things more confusing, some foals can be born completely normal and then deteriorate to becoming very sick after a few days, or even up to a week in some conditions. It is also not uncommon to have multiple illnesses or conditions occurring concurrently, or developing depending on sort of what conditions are going on over time, making treatment and sort of care a very fine balancing act. Now, you all have different levels of experience, I'm sure, and different levels of comfort in assessing foals. But obviously a really good rule of thumb is that if you feel something is not quite right or you're not sure, it is worth contacting your vet just to double check, because when these guys do become sick, they rapidly deteriorate. And I guess the best thing that can happen out of those health checks is that you've got a good bill of health following a check by your vet. Sorry, I just realized I didn't flick my thingy. So that's that. Working off 2 screens, so it might bear with me a bit. But The risk factors, I guess, that kind of give rise to when you are suspecting an ill foal, or to look out for a foal that's not quite right, is dystocia, premature deliveries, red bag presentations, placentitis, twins, maternal illnesses such as sort of anemias, any sort of cardiovascular, pulmonary disease, colic, anything that might decrease blood flow or oxygen delivery to the uterus whilst the mare is pregnant, and then a history of previous problem foals. If you're sort of seeing any of these in your mares or during the foaling, you know you have a high risk foal potentially coming out, and you just need to look at these guys a little bit more frequently than you would an otherwise normal foal. And it might just be something where you do sort of go, hey, I'm just going to get a check straight off the bat, just so you know that you're not missing anything that's quite subtle or hasn't quite presented itself yet clinically. So just a reminder, but I guess one of the critical stages where we do find a lot of that sort of lack of oxygen to the foals that can predispose to a lot of these sick foals is that stage 2 of foaling. So again, I'm sure a lot of you guys know this, but just going over what we want to see is that white grey membrane or the amniotic membrane, which the foal is inside. If you see a red membrane or a red bag, then that means that the placental membrane supplying the oxygen to the foal has separated, cutting off the oxygen supply, and that does compromise the foal. It depends on the length of time. Obviously, some of them can actually have that and not be too affected, but if it has been quite a while until delivery, it can cause disastrous effects. It's always something to count as an emergency, and you do need to open that red membrane as soon as possible and get the foal out. So in normal foaling situations, after you see that white amniotic membrane, you want to see 2 feet, and then the nose should be seen ideally within 15 minutes. Usually this only takes about 10 minutes. But if this doesn't progress or occur, and the white membrane doesn't rupture on its own, it will need to be opened manually so that the foal can breathe. Once the foal is out and the mare is no longer in the white membrane, the umbilical cord will normally tear when the mare gets up. So if any of these stages are prolonged or they don't occur normally, the foal, if it survives, is at high risk of being abnormal, and it is recommended that a vet is contacted to assess the foal as soon as possible. So again, this is stuff that you probably are well aware of, just to kind of tick off these before we head into some of the conditions. So remembering that a normal foal will have a suckle reflex present within 5 minutes of birth. They are generally sitting in sternal by 10 minutes, standing within 1 to 2 hours, nursing within 2 to 3 hours, and then passing meconium within 6 hours. Urinations differ between colts and fillies. With colts, you're often seeing the first urination about 8 hours, and fillies within 12 hours. If any of these stages are prolonged, it can suggest that your foal isn't quite right and may need a bit of help. It is worth mentioning, and I'll go into this a bit more later, that even if the foal does hit these milestones and appears seemingly normal, they can go backwards quite quickly and I guess lose their suckle reflex and present quite sick. So going into some conditions. Our first one I want to touch base on is the dummy foal and neonatal maladjustment syndrome. It's also, I guess, known as neonatal encephalopathy. There's quite a few names for this condition, just showing that our knowledge of it is still ongoing. The classic dummy foal presentation is normal at birth, with foals having a good suckle, ability to stand, they can latch on and nurse, ticking off those normal milestones, but then they deteriorate over the course of the day and can do this quite rapidly. They also can present straight off the bat as being abnormal as well, and I'm sure you've all been familiar with those ones that just don't actually get up after birth or look dumb already following following birth. We're still not exactly sure how this syndrome develops, but what we think happens is that there is a deprivation of oxygen to the foal, and that occurs either in the mare in the perinatal period, during or shortly after parturition. The effects seen on the body depend on the body systems involved, and how much oxygen deprivation has occurred by that reduced oxygen supply. It most commonly manifests as a central nervous system damage. On top of the risk factors mentioned before in the above slide, other conditions that can predispose to dummy foals with sort of after birth, and this is kind of going into how conditions do overlap quite a bit, are failure of passive transfer, anemia or neonatal isoerythrolysis, sepsis, cardiovascular or respiratory disease, or prolonged periods of recumbency can sort of transition into having foals that become quite dummy following. Clinical signs that you will often see will, again, as I mentioned before, depend on the degree and duration of the inflammation and oxygen deprivation, but they're often foals that don't know how to get to the udder. They'll often aimlessly wander around boxes, head press against walls, show a bit of weakness. They seem to sleep and lie down a lot more than normal. They have a loss of coordination, hypersensitivity to sound or touch, and they can seem depressed or chewing or licking at stall walls. You can just see as the only sign a foal that's just a bit quiet with a reduced suckle, and then sort of once you presented to the vet, they can kind of deteriorate sooner. You can, I guess, one of the other main things you can pick up on is just that the mare's udder is a little bit full, just showing that the foal hasn't been getting up as frequently as it should have, and having a good nurse. They are also predisposed to aspiration pneumonia if nursing or being bottle fed. They often have kind of weak pharyngeal muscles that you can kind of hear as like a gurgling noise when they nurse. And they can have sort of what we call apneistic breathing, which is sort of rapid breaths for a bit, and then they'll kind of hold their breath, or they'll kind of have a very slow respiratory rate. The other signs that they can see that I sort of listed here will depend on what body system has been affected, but a lot of them will struggle to tolerate large volumes of milk, and sort of develop a little bit of ileus, which is just sort of in like guts not working well, where they get reduced gut function from that lack of oxygen supply to the guts, and then in severe cases seizures can be seen. Sorry. All right. I'm not going to focus too much on treatment, but I've just listed them there so you guys can have a look at them. But in mild cases, and I guess some severe cases as well, they can be managed on farm if you've got adequate staff and time. But most cases will need to be sent to a veterinary hospital. Once off the suck, these foals can deteriorate really rapidly just from a lack of hydration and calories from not getting milk. And they can benefit from being fed. So we if they do come into hospital, we pop stomach tubes in them and have them fed every couple of hours, as well as supplementary fluid support, and close monitoring of their hydration status and glucose status, and then of any secondary conditions that do develop. The prognosis does seem to be quite good. Roughly 80% of dummy foals, these are including sort of severe cases, tend to make a full recovery and go on to have good careers in high athletic ability. Our next condition, which again does overlap with the dummy foal syndrome. Again, if you've got a dummy foal that can't nurse, you are at high risk of getting failure of passive transfer. This is where you have an inability to absorb antibodies due to reduced gut fat, I should say you've also got reduced gut function that can stop the antibodies from being absorbed. But the reasons why you may have failure of passive transfer can be poor quality colostrum, particularly older mares tend to struggle a little bit. They can have sort of in previous years have really good colostrum, and then as they can deteriorate over time. Mares producing low volume of colostrum, sometimes maiden mares, or just there are just mares that that do produce low volumes, or they can kind of reject the foal, so the foal can't actually latch on to nurse. Going in the same train of thought, foals unable to stand if they're sick, also will not be able to get the same amount of colostrum as they need to pass to get those important antibodies. Mares running milk prior to foaling are also have sort of wasted their colostrum, and often by the time you get your foal onto the mare, they're often just getting less antibodies than they should be receiving, and it's no longer good quality colostrum. And then you have those conditions, as I mentioned before, where if they've got a reduced gut function, you've got this inability to actually absorb the antibodies. This makes them really at risk and susceptible to sepsis or infection, which is never good news. So I guess one of the reasons I should discuss why they are predisposed to getting that is that newborn foals enter the world without antibody protection, and they are completely dependent on receiving this from ingesting the mare's colostrum. Some things that can cause, move on to the next part. So ideally, this does seem quite a lot, but ideally a good rule of thumb is that you sort of want 2 to 4 litres of really good quality colostrum to make sure you're on top of the sufficient levels. They say that you cannot get as small as 300 mils of good quality, but you've got to be kind of hitting your target well if you're going to get that. So I think just to be on the safe side, making sure you are getting large amounts of good quality, to make sure you do kind of pass those IgGs and ensure that the foal does get that good immunity from the mare. The colostrum should look thick and yellow in colour, and have a really sticky quality. We advise our farms to get a Brix refractometer just to measure it, and this you want this to be sort of over 20%, and then you're happy that that's a good quality. If it's not, you've then got that opportunity from the start to start to supplement your foal with better quality colostrum. If you know, when you know that your mare doesn't have that good a quality. So IgGs, I'm sure you're all familiar with these. These are routinely performed on farm once the foal is about 18 to 24 hours of old, to make sure that they have received that good antibodies from the mum. At that age, the foal's ability to absorb protective antibodies across the gut lining is quite low and closed in most foals. And they do have the greatest ability for them to absorb antibodies is in the first 6 to 8 hours, which is why it's really important that they hit that 3-hour milestone to sort of have a nurse and get on the mare, because once they've kind of passed that, they will absorb antibodies after that, but it does drastically decrease over time. So just going through that again, if you've got, I'm sure you're all aware of this, but it's when it's over 8 grams per litre that we say that it's got adequate passive transfer of immunoglobulins. So what you can do in these cases, so I guess another thing is, if you know that the foal has been slow to get up or latch on, or hasn't nursed on its own before that 3-hour mark, tubing the foal with some colostrum can be something to sort of initiate on farm, just to hopefully try and avoid the foal getting to an age where it's not going to be able to absorb anymore through the gut. It is advised that those foals are closely monitored, and not to hold out until that 24-hour mark to do the IgG, but to do this sooner. So if you check them at 12 hours, you've still got some ability to sort of try and supplement them and get some antibodies into them orally. And so you can correct that, so by tubing them on farm with some good quality colostrum. If the foal is 24 hours or over 24 hours old, then quite often the best way to you will get little ability to increase the antibody status by tubing them. So you do tend to then rely on plasma infusions, which can be quite costly, but they do work really well. Yeah, so I think that sums most of that up. Again, just reinforcing the Brix refractometer to measure the colostrum quality. And you can, if you do the 12-hour IgG and then do some colostrum, then you can always repeat the IgG at the 24-hour mark, just to make sure that that extra tubing that you've done is actually hit the mark as well. So another condition that again has a little bit of overlap with the previous ones is prematurity or dysmaturity, or I guess in an unreadiness for birth. So just going into a technical explanation of these, prematurity is when they're less than 320 days with normal foaling, normal gestation being 340 days. Obviously, as I'm sure you guys all know, that each mare will have a slightly different gestation length. So one good thing, and it can be hard if you've got new mares on farm, but if you've got resident mares in, knowing what their normal foaling term or normal gestation term is, because that is often repeatable with the same mare. And that can help us determine whether the foal is likely to be premature or not. There are reports of premature foals less than 300 days surviving, but these are quite costly and they do have a very guarded prognosis for survival and racing performance. Dysmaturity is where the foals are over 320 days, but they have all the signs of a premature foal. So some clinical signs of these guys is that they are often underweight and small foals. They can be slow to stand and nurse. Domed foreheads is not uncommon, having a fine silky coat and floppy ears. They also can be quite weak, and a lot of these guys will have severe tendon laxity that you can kind of see in the one of the above images. A lot of these guys will be, just because they haven't been able to get up and nurse, they'll be dehydrated. They can also have abnormal respiration and mentation as well, and then the gastrointestinal signs that we've discussed before. Another big thing that we look at is whether they have got bones developing in their hocks and their knees, because that does give a prognostic indicator for their future, and does need sort of care and consideration going forward. Just because if they don't have those bones in there, they as they're putting weight on those limbs, it does mean that those bones can crush before they get to a point where they've actually ossified and look like normal bones. So it can be really challenging, because you ideally want to reduce, especially in the really severe cases, you want to reduce weight bearing to allow the bones to calcify before weight bearing occurs. In the milder cases, we will often recommend just having the foal in a box to minimize exercise and unnecessary trauma on the bones, and then doing follow-up x-rays after sort of 2 to 3 weeks to ensure that you're heading in the right direction, and that there's no signs of sort of any wedging or crushing prior to letting the foal be turned out. Again, in most cases, so yeah, premi foals, if they are mild, they can be managed on farm, but in most cases they do often have other things going on that do benefit from hospital care. Another thing that's worth mentioning is in premature foals that are from mares that have a history of placentitis, they do seem to do a lot better than those that have not had any history of placentitis, because that inflammation in the uterus and infection that's occurring in the placenta tends to stimulate the foal system to mature prematurely, and it just kind of gives them a bit more of a preparation for life outside of the mare. So they actually do tend to do quite well. We do really worry about those premature foals when they've had no sort of obvious placental inflammation. Our next condition, which is just going to be very brief because a lot of these guys do end up coming into a hospital setting, but is sort of recognizing septic foals. Again, there's a huge overlap, and all the conditions I've spoken about already do have an ability to progress or also have a concurrent sepsis as well. These these foals can often be born clinically normal again, but do go, like, progress to going off the suck. I think, again, similarly, you might just see that the udder is full and notice that the foal's not getting up as much. They can have a fever. They also can have low fevers, especially if they're going into shock. And they can very quickly dehydrate and get poorly perfused and cool extremities. You can see injected sclera and petechial hemorrhage, which is just little red dots inside the ears. And that the whites of the eyes can be injected or reddened. You can see uveitis, which is inflammation of the eye, and lameness if they do tend to get some sort of joints that get inflammation in them. Sometimes all you see is just a what we call like a septic joint. Liz will discuss that in our next presentation. But yeah, they also do tend to have respiratory compromise, enteritis or diarrhea. They can go on to develop seizures, and as I mentioned before, some septic joints or osteos. The foals can become septic in utero, so it doesn't need to, it's not necessarily something that just follows on from another condition. But as I said, there's a lot of these are concurrent, and they have more than one condition altogether. But and this is just the ability of foals to respond to infection in utero is much less than adults. It also can result from sort of otherwise I guess maybe not otherwise normal foals, but from foals that are born somewhat normally, and that they are then exposed to sort of unsanitary environmental conditions, from dystocia, poor health or condition of the mare, as well as we discussed before, prematurity and maturity. They can also be exposed to new pathogens in the environment, to which the mare hasn't developed antibodies, so they are unable to pass them onto the foal to help protect it. Which is why we stress that importance of some of the vaccinations in mares prior to foaling to just increase their immunity to sort of some of the pathogens that we expect foals will be exposed to. But there are obviously some things that we can't protect with vaccinations. So just again, treatment is very similar to above. Some of the above conditions, a lot of it's supportive, and so forth. But again, a lot of these guys will often need some sort of hospital care. All right, sorry, that's just the treatment slide. Diarrhea, which I've spelt really weirdly, sorry. But diarrhea, just again going briefly into diarrhea. This is probably something you guys have seen very, very commonly on farm. Clinical signs will range from sort of a low volume diarrhea with an otherwise bright foal to profuse pipe stream diarrhea with depressed foals that sort of crash quite quickly. They also can develop sort of quite like bloody diarrhea. That is really concerning because it can rapidly be fatal. So it is really, if something like that is happening, get onto your vet straight away. These foals are at high risk of developing sepsis or infections. So in most cases, they are protected with antibiotics. This does differ a little bit from how we treat our adult diarrhea cases, where we often do try to hold them off antibiotics. But again, clinical signs, depression, weakness, they can get bloody diarrhea. A lot of them will colic, and whether it ranges from mild or to severe colic does seem to depend on the foal, and they also can kind of pop up with some septic joints over time. So treatment, very similar to the above. We do seem to have some gastroprotectants, but a lot of it is just maintaining their high hydration, and it's really important to monitor their electrolyte and acid-base status. In some cases, you will notice that foals drink directly from the water troughs, because they're feeling quite dehydrated, which that can make their situation really a lot worse, and can drop their sodium levels dangerously low, which can sort of make them quite neurologic. At this point, contacting a vet to do some blood work is recommended. It might even be worth doing as soon as you sort of start to see some diarrhea, especially if they are depressed, to just assess where they're at with their electrolytes and acid-base status so that they don't crash. and you have to sort of bring them back from afar. Like if they just, sometimes you can just kind of give them a little bit to just mildly correct them, and it's a lot easier than having to bring them back when they have gone downhill quite a lot. Also good practice to get into cleaning their bottoms and placing some Sudocrem or Flamazine, or just some like Vaseline on the around the bum, just to protect the skin. They do scald really easily. Again, these guys, you've probably managed a lot of these guys on farm. It really depends. Milder cases can be managed on farm. Sometimes they just need sort of a little bit of a bolus of Hartmann's to kind of get them back on the suck, and they're all good again. But those that are really colicky and off the suck can benefit from short periods of gut rest and intravenous fluid support, which does tend to require hospital attention in that setting. So I haven't gone on to the treatment. It's not very good with my slides. Another, I guess, cause of colic is meconium impaction. As I was mentioning before, foals should pass meconium within 6 hours. You generally start to see meconium passing within 1 to 2 hours after birth, after they start ingesting colostrum. The colostrum itself acts as a laxative and stimulates the sort of gut reflex that just helps pass that meconium. Passage can be delayed, especially if the foals have some other sort of process going on, so the septicemia or the dummy foal syndrome we discussed before. And it is also worth noting that just seeing milk feces, so those soft orange coloured feces, does not necessarily mean that all meconium has been removed. So meconium impaction can still occur, but it's a nice sign to see. But do just keep in mind, if your foal's still colicking, you can't completely rule out that meconium impaction is not the cause. So colic signs can range again in these guys. They can be really subtle, such as general restlessness, stretching of limbs and recumbency, twisting neck, rolling onto back, and frequently straining to defecate or urinate. Just another thing, I guess, to point out, I think it can be a bit difficult sometimes to differentiate between when a foal is trying to strain to defecate or urinate. So when they do they defecate, they sort of have their back arched upwards, and they tend to have, I guess, what we call like a water spout tail, and they seem to have a camped under a leg stance. That is compared to, I'll just duck over to my next slide. So I'll go through this. So again, treatment, similar again, like in the terms of symptomatic treatment, but then we do have some added addition of some enemas. Just be careful again, and I'm sure you're all on top of this. With fleet enemas, you don't want to give sort of more than one a day. They can mess with the foals quite a bit. So if you're not getting any resolve of your meconium impaction following you giving a fleet enema on farm, please contact your vet, because you will need to think about doing a soapy water enema or a acetylcysteine retention enema. So going into just the differentiation, this is then a foal straining to urinate. So just to differentiate from the one before, they tend to have a flat or sort of like a flexed back, and that the tail tends to be held up. So this is another, I guess, somewhat common thing that we see on farm. Often what you see clinically is reduced nursing, increased recumbency. Some of them don't produce urine, but then some of them do produce small volumes of urine, but they do tend to they do sort of look like they just keep needing to urinate. And then over time, they will sort of develop a distended pendulous abdomen. I should clarify as well that uroperitoneum is just a ruptured bladder or umbilicus. But yeah, as the urine sort of fills into the belly, you do get that distension in the abdomen. And just a reminder that it doesn't always occur at birth as well. So it can develop and can take a little bit of time to be seen in foals, and can be sort of seen after that, sort of around that week old mark as well. So these guys, if they do tend to rupture their bladder, it is a surgical repair of the tear is necessary. They don't need to go to surgery straight away. A lot of the time we do need to stabilize them medically, but you do sort of need to get them on the table generally to correct what's going on. As well, but we will quite often they will have some electrolyte imbalances that put them at risk of anesthesia, so we do want to stabilize them first before putting them through that. Our next guy, which we've actually had one of these guys in hospital recently, is neonatal isoerythrolysis, or sort of hemolysis, where you've got an incompatibility between the mare and foal's red blood cells, causing the antibodies from the mare's colostrum to destroy the foal's red blood cells, and they get an anemia. So clinical signs of these is that they often are normal at birth because they haven't had the colostrum yet from the mare, which is the thing that contains the mare's antibodies, and then they do tend to develop signs of anemia at 8 hours to 4 days after birth. What signs you see depends a little bit on how much reaction you're getting between the antibodies and the red blood cells, but you will often start to notice the foals becoming lethargic. They go off the suck. They will get an increased heart rate, increased respiratory rate. You can see yellow mucous membranes or jaundice after a couple of days, and there is they can often have some sort of concurrent infections as well. So treatment for these is to hold them off the mum. In some cases, you can get them onto mum less than sort of 36 hours as well. But if you're not sure and you have no way of measuring what am I trying to say? Sorry, no way of measuring the antibody concentration in the milk. It's probably wise to hold them off for sort of 36 hours and give them support. Elsewise, you can, but once the gut has closed, or you're happy that the gut is closed, and the mare is not producing colostrum, so you can do a Brix refractometer measurement, and if it's less than 12%, then you're pretty safe to get them back on mum. Then that's okay, but it is just that immediate initial period. These foals usually do have a good transfer of passive immunity, which is often that they've had that large amount of colostrum, which has then caused the illness. Another important thing is just to avoid any stress. If you can kind of keep them in a quiet area, just to stop them from utilizing their oxygen, which is when they don't have those red cells, they can't get the oxygen to the organs that they need to get it to. So that is what most of these clinical signs are secondary to. So I'm almost done, so I'm sorry I've probably gone a little bit over, but some other just brief conditions. Again, I'm not going to go into, again, sorry, I forgot to move my slide on. Apologies. Just let you sit on them for a bit. But yeah, just some other conditions, which I won't talk about too much, but just some foals obviously can get some contracted tendons, they're quite common. There's a huge range in severity. Sometimes we will need to give them some sort of oxytetracycline to help relax those tendons, plus or minus sort of support them to get them into some splints or some casts and some physical therapy. The oxytetracycline doesn't do a huge amount unless you can actually put some weight through those tendons to help stretch the tendons out. So it really is important to have a combination approach or combination therapy approach. Rib fractures is another one that is quite common, especially in your big dystocia foals. And then you've also got obviously congenital abnormalities that have a huge range. I think there's a huge range of congenital abnormalities, some of them being cleft palate, scoliosis, rhinos, and they all have different success rates and whatnot. So there are some weird and wonderful things. So just again to reiterate that many newborn foal conditions are on the spectrum. They can be anywhere from mild to severe. Foals can appear normal at birth and then rapidly deteriorate. Making life a little bit more complicated, especially for us vets, is that there can be multiple conditions occurring at once. And so, as I said previously, it is a little bit of a fine art in what to address first and how to kind of balance all those conditions at once without doing harm. And I guess foals can literally just be, the first thing you might notice is just a little bit quiet and not nursing well. So that is all for me. Just I guess take home note, early intervention is key. The earlier we can identify problems and treat them, the better the prognosis, and hopefully it avoids them deteriorating rapidly and racking up those kind of big veterinary bills. Sometimes it is unavoidable, obviously, but I do think if you are worried, quite often we can treat them on farm and avoid a lot of them getting into hospital if we do get to them early enough.
So Marina's asked here, can giving a dummy foal oxygen improve or reverse the problems?
Improve or reverse?
Yeah, the problems.
Improve. They do. A lot of them do need oxygen as well. Sometimes you will find, especially if they have been critically ill, sometimes I think the only time you kind of like the foal does crash after getting support is that their body, it's almost like they get an adrenaline rush when they're crashing, and sometimes you can give them oxygen and get them on fluid support and whatnot, and it's almost like their body just relaxes into going, hey, I'm getting the care I need, and it then realizes how sick it is, and then they crash. But in most cases, oxygen is exactly what you want for them. So we will have all our dummy foals that come in will have oxygen at least for 24 hours, and then we'll assess whether we need to keep them on it or not.
Okay, we do have a few more, so I hope that answers your question, Marina. Now, Jessie has said, how often can you tube a foal that is under 24 hours old? There's a few questions here. What is the maximum quantity per tubing? Interval, minutes or hours between tubing? So, and there's a few questions. So we might start with, I'll let you work through that. So how often can you tube a foal that is under 24 hours old? What is the maximum quantity per tubing? The interval, minutes or hours between tubing? And there's a bit more to it, but we'll break it up.
All right. It really depends is the answer to that. So in a really healthy foal, you can, like what we kind of do, and again, it depends a little bit on what's achievable on farm. Like foals will drink small amounts frequently, so as normal, but in tubing you sort of do get a bit hard pressed to do it more than every couple of hours, I think, either on a farm situation or even in hospital sometimes. So we'll often tube these guys every 2 hours, and then depending on what's going on, if they're an otherwise healthy foal, they can tolerate quite a lot. If they are sick, especially your dummy foals, septic foals, we start with just a small amount, so even as small as 50 mils, just making sure that they tolerate it and they don't develop any reflux. Just remembering that obviously foals can't vomit, so if you do overload their bellies, you do put them at risk of rupturing their stomachs. So when you it's a hard question. It's really case dependent. But yeah, I guess, and especially if they're down a lot, you also don't want to overload their bellies, because again, it can put more pressure on their stomachs and cause them to rupture. But your really healthy, vivacious foals, I think, I guess it depends. Like if they're sick and to the point where they're needing to be in the mum, we often sort of get them up to about 700, 800 mil. Ideally, they probably could have a bit more, but you do worry that there's too much going in there. And at that point, if they are being able to tolerate that much, they should really be nursing from mum or a foster mare at that point.
Okay. We have a little bit more to that question. I thought I'd break it up and make it a little bit easier.
No, that's all good. It's just a difficult one.
No, that's okay. Is there a proper, in commas, way of thawing frozen colostrums from other mares? And can we refreeze unused thawed colostrums? And thank you.
We usually just use like a bain marie, so just like warm hot water, warm water, and just a slow process. I've not tried to refreeze mare's colostrum. I don't know. I guess that every time you thaw it and you refreeze it, you are putting that colostrum at risk of getting sort of like bugs and stuff in it. So you've just got to keep in mind that if you've got an otherwise ill foal that's already susceptible for getting infections and things like that, do you really want to put something that may have got bacteria and whatnot building up in it? I would probably hesitate not to. I'd avoid doing that, I think.
Okay, very well answered. And I think we've answered all the questions. Now, Alex, thank you for your time. We are going to have a short swap over of computer. So we're going to try and swap Alex and Liz's presentation over now. So I might get Liz to jump onto Alex's computer and see if we can swap over the presentations. Liz is presenting tonight on the lame foal and septic arthritis in the foal. Liz graduated from Liverpool University in the UK in 2005. She completed 18 months at Scone Equine Hospital as a surgical intern before joining the University of Melbourne as surgical resident from 2007 to 2010. Liz became a fellow of the Australian College of Veterinary Scientists in equine surgery in 2012 and has worked as an academic staff member and surgeon, seeing surgical and lameness referral cases, as well as mentoring veterinary students and residents, specialists in training, at the University of Melbourne until July 2021. Liz has recently joined the Avenel Equine Hospital team as a registered specialist in equine medicine. She has extensive experience in lameness diagnostics, including the use of advanced imaging. With many years of experience with nuclear scintigraphy, that's testing my abilities there, bone scans, CT and MRI, in addition to the more commonly used techniques, X-ray and ultrasound, Liz is well placed to determine the optimal method for investigation of equine lameness. Liz enjoys the emergency caseload that arises during the breeding season and has particular interest in the surgical management of colic. And as a reminder, do feel free to pop your questions in as we go through. We'd love to hear them, and I'll hand over the virtual floor to you, Liz. Take it away.
Thank you, Charmaine. And thank you very much for the invitation to speak tonight. I'm really excited to join the team here at Avenel. This meme is quite representative, actually, of the lameness caseload that I'm used to dealing with. And I'm not suggesting the horses actually fake lameness, but it certainly can be a challenge to figure out what level of lameness and what conditions affect athletic performance, because it does seem to vary between horses. So that's one of the challenges of lameness diagnosis that I particularly like. In a mature horse, injury is due to repeated loading, and that's a result of the job that we ask them to do. And the discipline that the horse performs determines to some extent what the site of injury is going to be. And so we can use that knowledge to keep a close eye on these horses through their training and monitor them for injury and hopefully mitigate the risk of serious injury occurring. But today we're here to talk about foals, and of course no lameness is really acceptable in a foal. By far and away the main cause of lameness is going to be of an infectious origin, just with a small proportion of traumatic or accidental injuries. And because the lameness in these cases is often very rapid in onset and it can be quite severe, it's really easy to make the mistake of assuming that a trauma has actually occurred, such as the mare stepping on the foal. But that's actually, as I said, a small proportion of cases. And so we need to be aware that infectious disease is the prime candidate and looking out for that. And as my nephew down here likes to do, he is going to meet many bugs playing in the dirt. And of course, foals are no exception. They're going to meet bugs in their day-to-day life. And whilst they're immunologically immature, that presents a hazard to them. And it's really the density of bugs, or the number of bugs, or if they meet some particularly nasty type of bug, that they're at risk of picking up an infectious process in the bloodstream. So with that in mind, we can think of some fairly obvious management things that may reduce the risk of causing lameness relating to infection. So overcrowding or poor ventilation are going to be a risk factor, such as, as is having any umbilical problem with the foal that can act as a portal for infection or as a nidus of infection. The high-risk mares, which Alex has already spoken about, if we have a history of placentitis, then we know that those foals are going to be born with the potential for circulating bugs. So the main routes of infection are through the lungs, through the gut, and as I said, also through the umbilicus. And the diagram just here on the left, you can see the marker, shows a simplified joint, and the bugs that enter through these portals can circulate in the bloodstream and like to localize in the bones of the joint or the joint itself, or even sometimes in the muscle. So the key to this is maximizing immunity, and I won't speak too much in detail about this because Alex has already done a really good job of that just now, but making sure that the mare's colostrum is of good quality, and importantly that the colostrum is that the mare has been exposed to the environment that the foal is going to be born into for sufficient time that the colostrum contains the antibodies that are appropriate for that environment. So that's really, a minimum of 2 weeks, but preferably 4 weeks in that environment to make sure that it's going to be an appropriate immune response. Of course, your routine vaccinations are going to play a role as well. And any foal with a history of failed passive transfer is not only at greater risk of developing a septic joint, but those foals don't do as well when they're treated for that septic joint. So ensuring adequate colostrum, checking IgGs is really a key management factor that we need to be focusing on, as I'm sure you all do. Now, just check my video works. The age of the foal can influence when and where the infection crops up. Neonates, so certainly the first week of life, tend to infect the joint and the synovial cavity itself, with a smaller proportion developing bone infection. Whereas older foals tend to localise in the growth plate, and they may or may not have a concurrent septic joint. The presentation, just want to go back there. The presentation of these foals includes one or more of lameness, joint swelling, or swelling local to a joint. So I'm just trying to think my video does work. So this foal, you see it has a mild left fore lameness, got head lift, no. This is not a great video for the hind limb, but I think you can agree looking at it now that there's not an overt hind lameness, but we can see as he walks past that huge effused hock joint here. We can even see it bulging out the front. So in spite of the low level of lameness, we need to have a high index of suspicion that that could be a septic process beginning to start, and we need to be right on to checking that. In the hind legs, tends to be hocks and stifles in my experience, and fetlocks are also quite a common location. But really any location, and including those that are in tricky areas to palpate, such as the pelvis and the spine, can be affected. Typically, we're going to have evidence of systemic infection as well, so that may be fever or evidence on your blood work. Excuse me. So these foals need a very thorough workup, given that we've potentially got systemic infection as well. Certainly a joint sample needs to be taken, and this is an extreme example here in the top, but you can see this is essentially pus that's come out of the joint, normal joint fluid. I'm sure many of you have seen, you should be able to see through it. Part of my assessment that I think is really important is to ultrasound the joint, and we're looking at the quality of the synovial fluid, So at the top here, the black is the synovial fluid, and it's more speckled than it should be, which indicates that it's got some cellularity in there, which is the normal response to infection. But it's relatively clear as compared with this down the bottom. This, I'm outlining here the contours of this joint pouch, and we can see all this grey material throughout the joint. And this is the products of inflammation called fibrin, and the bugs like to hang out in that. This is a more advanced, more established infection on this ultrasound here. And the relevance of that is that when we're determining our treatment options, there are methods that are more suited to one or other scenario. So it's really important information to gather. In addition to this, we're going to take some radiographs, and these are actually of that little Arab foal that we just saw walking up and trotting up and down. And this just demonstrates the utility of different imaging techniques. Now, if we look at the top panel here, these are all radiographs, just slightly different angles of that left leg. And I think you can appreciate there's a little bit of lucency up here, and particularly on this far right one, it's a little bit more obvious. And this is infection within this main bone, the tibia, and extending likely to the growth plate, although it's not that easy to identify within the growth plate. When we look at this image, these images at the bottom here, this is CT, so this is a three-dimensional imaging modality, and we're able to just slice through the joint at different locations. So it gives us much more detail. This can be really useful in surgical planning if you have this option. Here is the affected left hind, and this is the normal right hind for comparison. And we can see this huge defect in the bone, which correlates with this on the radiograph, and it extends right through the growth plate and actually down into the joint. So this is why this foal has a concurrent septic joint. And a colleague and I actually looked at diagnostic utility of radiograph CT and ultrasound some years ago. And of course, CT is the most sensitive for picking up bone lesions, but ultrasound actually was extremely useful, and more so than radiographs, for identifying early onset of bone infection. Okay, so treatment principles. Predominantly, we want to reduce the infective load in the joint and in the foal itself. In terms of the synovial cavity, we go about that by lavaging out that joint compartment. And this is why I said that the ultrasound is really important, because we can see that this large amount of material within here may be actually quite challenging to remove, and may need a physical, a manual method to do that. For example, an invasive surgery, and I'll show you some pictures of that shortly. It's really important to remove this tissue, because this is where the bugs like to hang out. So if you're not able to do that effectively, then you can really struggle to get on top of these infections. We may need to debride bone if it's involved, although that's done on a case-by-case basis, because certainly not all of them need it. Antibiotics, of course, are going to be adjusted according to culture and sensitivity results in the lab. But before that information is known, we're going to start off with a broad spectrum approach. So here in the top left, this is to demonstrate the different methods for synovial lavage. This is an adult horse, but it just demonstrates the point. A needle lavage, which just entails needles being put in all of the various joint pouches. And this horse is under anaesthesia, but foals you can do sedated very often. And you can see it's a relatively non-invasive method of flushing the joint, and it can be very effective, and really all that's required in those cases that don't have that thick material evident on ultrasound. But you can imagine that that material may not come out through these needles very well, because they're obviously of a finite diameter. This is the alternate. It's somewhat of a long video, so we won't watch all of it, but this is actually an adult joint that we're looking in with the arthroscope. This is the end of the cannon bone here, normal white cartilage visible. And then over on this side of the condyle, we've got all of this horrible yellow and inflamed looking material. Some of this is fibrin, which is a product of inflammation. This is actually, in this adult horse, this is actually post-penetrating injury to the joint, and it has a bone fragment here that's going to need to come out as well. I'll just let this run for a little while. So you may not have seen, had the opportunity to see what goes on in surgery, but you can see how this thick material here really needs a physical method of debridement. It's not going to be flushed out very easily through a needle. Just using a motorized instrument here to free up this bone fragment. And in a moment, you actually see some hair that's penetrated the joint, which is not uncommon actually with traumatic injuries that penetrate the joint. Another reason to be able to look in there with the arthroscope, so you can ensure that you get all of that debris and material that might act as the nidus for infection out of the joint. I think we come up in a moment on the, oh, there we go. So there's a fairly large amount of hair sitting in there, so you can imagine that that needs to come out. But we are a bit behind time, so I'll just perhaps move on. If you want to watch that, then it'll be in the recording. So methods of antibiotic delivery. Obviously, we're going to use systemic antibiotics, but sometimes we need to try and increase the concentration of them at the site of infection itself within the joint. And we can do that using a few different techniques. This is an example of a intravenous regional perfusion. The foal is sedated, lying on its side, and we have a tourniquet, in this case above and below the joint that we're concerned about, which is the hock. And it's perhaps a little bit difficult to see, but we have a catheter here into the main vein that runs over there, and the vet is injecting a solution here of antibiotic. And what that does is to concentrate the levels to extremely high concentrations in this area. And when we let that sit for a while, and when we take these tourniquets off it goes into the body. But it's a really useful technique to try and get extremely high levels, which if you just injected into the Foals vein, you would have to use huge doses to achieve that same concentration in that joint. You can also inject directly into the bone, and that's quite useful when you have bone lesions, and I like to use the ultrasound to guide that so that I know I've got my injection in the site that it's needed. Or you can put it directly into the joint. Not forgetting the rest of the foal, as we said at the beginning, these infections come often from a systemic source, and so we may need to address that specifically on its own. So things like umbilical resection, which this is an image here. This is the foal's abdomen open. Here's some gut. There's a horrible thickened umbilical vein, and this is it opened up on the right here, and you can see the pus pouring out. So resecting that surgically can be really beneficial to reduce that potential for these bugs to keep seeding off through the foal's bloodstream. For foals with pneumonia, you can also nebulize antibiotics to increase the concentration at that site. This is a foal that we saw last year, actually, and it's a relatively uncommon manifestation of infection, but I thought it was a good example of how important it is to be aware of addressing all sites of infection. The history was of a left hind limb lameness. It was relatively mild, and it was somewhat intermittent, but becoming more consistent in the few days prior to referral. The foal had a fever and evidence of inflammation on its blood work, and it had received a couple of different types of antibiotics over sort of the preceding 7 to 10 days, and it really hadn't resolved anything. And we were able to find, when we examined the foal, abnormalities in the other legs. So we had some evidence of low-grade sepsis in the right knee. We had an osteomyelitis in the right hind fetlock and also in the stifle, but we couldn't find anything in this left hind limb, which was the main concern in terms of lameness. So we went ahead and CT'd this foal, and this is not saying foal, but just to demonstrate the technique. They go on their back, if they're provided they're under a certain size, they fit on this human bed, and it's motorized and it drives through the CT bore, which is this circular machine here. And if you want to, you can scan the entire foal in actually a relatively short period of time. So it's a very useful technique to use. And this is what we found. So just to orientate you, this is obviously the foal, and this is a skeleton. And here we have a lumbar vertebra, so we're at this sort of level just in front of the pelvis, and we're cutting transversely, and the slices will head back sort of towards the tail end and stop at about the level of the hips. So I'll play that. So we can see the pelvis coming in here, that was the wings, here are the hips. And this is the abdominal cavity here with all of the organs in it. And just freeze it here. What I want you to just focus in on is sort of shades of grey, but this musculature here, and if we compare it with the opposite side, you think you'll appreciate that the left side is quite a bit bigger. And we can see this dark area here within this left side. And these are muscles. These are epauxal muscles that provide some hip flexion, but this is very abnormal. And this is actually an abscess in one of the muscles. Here's an image that perhaps better demonstrates it. And it's this muscle that we're talking about. This is the iliacus of the iliopsoas group, this one and this one together. And as I said, they're responsible for hip flexion. And with the benefit of the CT, we were able to use our ultrasound and go to the foal and find that abscess on the foal ultrasonographically as well. And this is us flushing the abscess cavity. So we inserted a cannula in under ultrasound guidance, and we're able to aspirate a lot of pus and flush it out for a number of days, actually was required. But this foal actually did really quite well. But this really demonstrated to me how, we were getting nowhere until we did that test. And so, always keep looking and keep revisiting, what your diagnosis is, because if they're not responding, it may be that we've missed something, and we might need to just look with a different type of imaging. So, most importantly, how do these foals do? Well, there's a number of studies out there that have looked at this over the years, and there's a fair bit of variation, but it's very difficult to compare one study with another. Overall, the survival actually is quite good, and there's these two papers out of Scone, which are the largest scale studies that have been. The first one by Kirsten Neal, which looked solely at osteomyelitis, and then the second one, Thomas O'Brien, published only last year, a large number of foals with septic arthritis. And in this latter study, there was comparison with the maternal siblings, and the proportion of horses that raced, or the proportion of foals that raced, was no different between those that suffered with septic arthritis and those that didn't. So, that just demonstrates that it is worth pursuing these foals. But a few important prognostic indicators came out of that study, and also have been found by others. Foals that were younger, so particularly less than a month old, foals that had multiple sites of infection, and foals with a history of failure of passive transfer all had a decreased chance of survival. So again, just underscoring the importance of that attention to cholesterol antibody in the early days. And that's the end of my talk. This is just a demonstration of the various different types of animals that I've investigated lamenesses on over the years. Donkeys are not willing trotter-upperers, but luckily they only tend to get laminitis or arthritis, so they're quite easy to diagnose. This is a young camel that I didn't go near until it was anaesthetised, but it was also very easy to diagnose. It had a fractured P1 that we were able to repair. And then this old tortoise, which my resident and I were very fortunate to get to scope the elbow on. It had some arthritis as well. I think they lived to about 50, so not surprising.
Thank you for joining us, Liz. I would like to thank both Liz and Alex for joining us tonight. It's obviously a busy time of the season, and it's very kind that they've given up their night with us. And I'd like to thank everyone who's on the call as well. I know how busy we are at this time of year, so to be able to give up your night when it's almost everyone's bedtime, I really appreciate that. So look, I hope everyone has found these webinars who have joined us from the whole way through useful in your lives. We will send out a survey again next week with the recordings, and I really encourage you to fill that out. It will help us tailor the webinars in the future. This is our second year now of doing these as Thoroughbred Breeders Victoria, and we hope that we can continue them and expand upon them. Obviously we went virtual due to COVID, but they seem to have worked out really well. So look, I encourage you to fill that out, and I'd like to thank everyone for their time tonight and wish everyone a safe and prosperous season, and thank you to our friends at Avenel Equine Hospital.